Welcome everyone. It's my pleasure to welcome you to our annual conference, to join Shane in reinforcing his welcome to you. This year we've got 440 delegates, which is a great turnout, and so I want to thank all of you who've made the effort to come. Some of you attended some workshops yesterday, and many of you have managed to take some time out of a very busy work schedule to be here, and I want to thank you for that. Particular welcome to overseas attendees and delegates. We have people from New Zealand, Bosnia, Croatia, Saudi Arabia, and of course our guest speakers, Kathy Shane from the United States and Dr. Michael Wilke from Germany. So we're actually meeting at a time of, as you heard from the chairman, enormous momentum in the ABF system in Australia, but also some changes ahead. I'm going to talk in the mechanics today about IHPA's processes. You'll hear a lot of debate and discussion about policy issues later in the program, and you'll hear an international perspective from Kathy Shane later this morning. And as we hear what's happening elsewhere around the world, we'll then start to drill in what's happening in Australia. But this morning I'm going to talk a little bit about our processes and how we actually deliver in IHPA the price outcomes that you are implementing around the country. And later on in the program, you'll also, following some feedback from last year, we're going to try and make sure we increase the local participation in this conference by zeroing in on some implementations in the local health workplaces across Australia of ABF. So that's the sort of theme of the conference, a start in a broad sweep, and then we're trying to zero in as we progress on local implementation. We're very keen to hear what you think of the conference. I'll wrap it up at the end along with the colleagues, but your feedback through the feedback forms will be really important for next year's conference. As the chairman said, we'll still be here next year. The target date we've been given for amalgamation with other agencies is 1 July 15. We're waiting on confirmation of that, and the Minister will make an announcement when he's ready. But we'll still be here next year at this time of this conference, so there'll be another ABF conference next year. So your input will be very important, and we appreciate it. So how does IHPA actually do its work? You heard from Shane, our role is to independently set the national efficient price for ABF services in public hospitals. We also have an important role in determining any loadings to the national efficient price, which is a constant source of discussion between us, states, territories, and our major national stakeholders. And we also define what is a hospital service, which has been a very intense discussion over the last 2 years, although we think, maybe we're kidding ourselves, but we think it's starting to settle and that we must be getting close to a reasonable definition of what is a hospital service. It's important, as you know, that definition of what is a hospital service, because it actually defines what is eligible for Commonwealth funding under the National Health Reform Agreement. There are some other Commonwealth health agreements. There are some other Commonwealth funding lines, but as far as the Health Reform Agreement, IHPA defines what's in scope. We also have to specify all the classification, costing, data and modelling standards, and again, constant interaction with the sector is important here. We meet regularly with states, territories and the Commonwealth through our Jurisdictional Advisory Committee, and we meet about 4 times a year with a National Stakeholder Committee and 4 times a year with a National Clinical Advisory Committee, each of whom have a say in these major policy documents and process manuals that IHPA designs. But it's a constant interaction between stakeholders, and it's a constant process of improvement. Everybody in this room knows that ABF is an incredibly data-rich human exercise, and therefore it's inherently prone to data error, but also prone or fertile ground for improvement. So our philosophy has always been never to be satisfied with any of our work in classification, costing, data and modelling. We look to continuously improve our work in each of those disciplines. We're very lucky to have some highly expert staff who've strengthened their own expertise in recent years and have led those each of those disciplines. So we have a classification group and we have a costing group, and we also have a highly expert modelling team as well, many of whom are here at the conference. If you want to grab them, you can see them on your delegates list. We also have to define the criteria for defining block-funded services. Most of you know, I think, that over 450 small rural hospitals in Australia are still block-funded. They only account for 5% of hospital activity, but they do account for nearly, in fact, over half of the hospitals in Australia, but only 5% of hospital activity. And so there's still a strong element of block funding in our system. And of course, teaching and training is still block funded. It's our role to define where that block funding boundary ceases and where the ABF boundary commences. And after some 2 years experience with our first 2 NEPs and our third just delivered, we're pretty convinced that we do need to shift the block funding boundary just slightly, and you'll see that those numbers come out in the near future. So in completing these roles, we have to do, we follow a cycle of work that is important for everyone in the room to get involved in if you're interested in ABF. And I'll show you that there are many ways you can get involved. The first thing we do every year is we start to debate with our stakeholders, and particularly the jurisdictions and our clinical advisory committee, the pricing framework for the following years. So the pricing framework is our key policy document. We update it annually through public consultation, and in fact, there's an email that goes out later today, and it's in fact churning its way through the Ethernet as we speak, inviting organisations to comment on the 2015-16 pricing framework. And also we'll be exhibiting publicly advertisements calling for organisations or individuals to comment on our pricing framework. This is the key policy document that we work on every year. There's essentially a 4-stage consultation process. First of all, we start with a discussion paper, and that's the document that's being released today, and a closure date of 27 July for comments if you're interested. But you'll see it on our website if you're interested, or if you run a national organisation, or if you're part of a jurisdiction, you'll receive an invitation to comment through the usual processes. An email goes out to all national organisations inviting comment. So this is our key commencement of our discussion process. We use that issues paper to filter or in fact extract as many issues out of all our stakeholder community as we can, and then we start to distill those issues into a set of policy arrangements for the coming financial year, and we form a draft pricing framework which in itself is consulted amongst mainly jurisdictions at that time, and then finally a final pricing framework. So there's a long process of iteration on policy issues before we do any work on the mathematics of setting a national efficient price. So our pricing framework outlines all our key principles that we use to price, the scope of our pricing, and the methodology we use to price. And it also defines what's in scope. And as I said, over the last, in the first 2 years of IHPA, we spent a lot of time trying to define what is a hospital service, which is a uniquely Australian debate. In in single jurisdictions or single health jurisdictions like England, New Zealand, they often look at me perplexedly asking why on earth do we bother defining what a hospital service is. but in Australia it's important because the Federation is clear that the Commonwealth's role is contributing towards hospital services through the NHRA, and so it's our job to define what those hospital services are. So you'll see in our document that goes out today, our latest definition of what a hospital service is. You all know it's easy to define on-campus services. Inpatients, ED and on-campus outpatients are easy. They're obviously a hospital service. But you will also know that that extension of the hospital into the community has been a driving force of healthcare reform in this country and others for 20 years, and it's IHPA's role to make sure our definition of hospital service supports that key strategy of every provider in the country, be it public or private. And so that's why we've deliberately embraced that reform through defining a whole range of community-based hospital services as in scope. And we think we've got it nearly right. The change between our second and third versions of our scope definition were only very minor. So we think we're nearly just about right. But if you think we're wrong, let us know. Many of you will be running services that perhaps we've never heard of. So it's important for you to let us know if you think our definition of hospital services has fallen behind the times. So when you make a submission to us, I thought I'd give you a little bit of gratuitous advice, which you all know. But our most effective submissions have been those that understand IHPA's role. So we get the odd submission that asks us to change the MBS rate for XYZ, and obviously we don't extend to that role. And we also get submissions that ask us to change the National Health Reform Agreement. We can't do that. That's not our role. That's COAG's role. Some of them come from the States, mind you. Some of them ask us to change legislation, which we can't do. But the most effective ones are those that understand our role and critique our guidelines, and we get some rather pointed but very well placed critique, and also carefully dissect our policy framework, and particularly those that point out any lag between clinical development and our policy framework, clinical reform and our policy framework are the most effective submissions. So here's an example of an issue that we still haven't quite fully fixed yet. So this is a very live issue in our policy framework. At the moment, we recognise intensive care use as a key factor that requires special recognition in our pricing in the DRGs where it's not expected. So there are a range of DRGs where ICU use is nearly universal. Very preterm babies, very premature babies, almost always go to some form of neonatal ICU care. So we don't really need to recognise that beyond pricing the DRG properly. But in other DRGs, it's not expected that the patient will go to ICU, and where there's a 50% chance that the patient won't go to ICU, and they do, we add a loading. And the question we've been grappling with over the last 3 years is, in those circumstances where ICU admission is not expected and the patient goes there, how should we recognise that? How should we define it? How should we recognise it, and how should we load it? So we've had an intense discussion over the last 3 years with jurisdictions who've got the data and also their own clinical advice, the experts in clinical care, and you can see them listed at the bottom of this slide, and pricing experts. And we're still yet to fully resolve an issue, but over the last 12 months, we do think we've made some progress. We used to use, at one stage we proposed using the use of mechanical ventilation, which is well recorded in the data, as a marker for ICU use. But in fact, the clinical advice was that that would be a bad thing to do. It would encourage what is increasingly a dated practice. And as a former clinician, it's while since I've cared for ICU patients, but I used to do a lot. It's been a good instruction for me to catch up with the colleagues a bit. So in fact, we were talked out of using what would have been a very blunt and dated instrument to recognise ICU use in that unexpected use group. So we were talked out of that through a very positive discussion with ANZICS, the College of Physicians, the Thoracic Society, and intensive care nurses as well. And so as a result, we've made some progress towards a compromise where we now load ICU use based on a combination of ICU throughput and ICU mechanical ventilation percentage hours. But again, that's still criticised as somewhat dated. So in the next 12 months, starting with this round of submissions coming, we hope to improve that further with a better collection of data that reflects resource use in the ICU. So this is an example of us iterating with governments and other stakeholders. And I just draw your attention to the fact that if you feel that there are issues that we're not dealing with, this is the sort of process open to you, particularly if you have a government that you work for or a national stakeholder that represents your interests. We can work through the issue with them in the similar sort of fashion to the way we've been resolving, or at least partially resolving, our ICU adjustment issue. So once we've set the policy framework, we collect the data. And of course, all these things happen in parallel. They don't all happen as a stepwise progression, but for the purposes of today, we'll assume they're in a stepwise process. So we're very lucky in Australia to collect cost data through the National Hospital Cost Data Collection, which is a resource much underappreciated in this country. And I suspect the people who made the decision to establish the NHCDC in the mid-90s are still working in the system and probably attending this conference. But as leaders of the system, they introduced one of the world's great data sources in the mid-90s, and it has endured, and it provides probably the richest source of public hospital cost data that I'm aware of in the world. When I speak to the English, and for that matter the Scottish and Welsh, to a lesser extent New Zealand and other public hospital providers around the world, there's often a great envy of our National Hospital Cost Data Collection. So we're about to collect round 17. In fact, from memory, we've just done 17 and are in the process of refining the collection. So this shows you we've got 17 rounds of rich, not universal, but highly prevalent hospital cost data right throughout the country. It's a very rich source of information. It's not perfect, and the lower down you get in the chain, the less perfect it becomes. But at national level, once you aggregate all this data up, it's an amazing piece of work. And the pioneers who established this in the mid-90s should be celebrated. I wouldn't give them a knighthood, but perhaps they should be recognised in some other form. So we're now at the stage where we're collecting data from well over half the hospital separations in the country. And we now have millions and millions of lines of patient-level data. And so this work is extremely important, and those of you who, and there are many people in the room who do the hard work, not only at local level, but at jurisdictional level, and then within our group. Those of you who work on this hospital data collection, I'd urge you to continue to remind your leaders in your various organisations that this is truly useful, and it's an amazing piece of work that leads to really important decisions being made properly. We now manage the NHCDC, and obviously will recommend to the government that when the new Health, Productivity and Performance Commission is formed, that commission would have a very important role in governing, or at least managing, the NHCDC along with partner jurisdictions. So it'll be a very important process that will continue. So we use the National Hospital Cost Data Collection as the basis for designing the National Efficient Price. We do trim some errors, and that actually is one of the reasons why it takes some time to use the NHCDC for pricing purposes. We do have a round of iterations with the jurisdictions where we bounce the data backwards and forwards to refine it, and it takes a couple of months. So we're actually keen to get rid of that couple of months because some jurisdictions are asking us for a more accelerated pricing process, which is fair enough. We'd like to do that. But in order to do that, we need to cut out the series of iterations that we have with the jurisdictions over the quality of the data. So if we can cut that couple of months out, we'll be able to deliver a price 2 months earlier than we currently do. And we use that data, we aggregate it all together, and eventually we hand it over from our costing team to our modelling team, who generate the national average cost for that particular year that we collected the data, and obviously the various distribution of costs away from the average. And so this is a very important process, and it's transparent, and we're able at any time to show you, if you work for a jurisdiction or a national stakeholder, exactly how we do it. So to determine the NEP, once we've gathered all the costs together and defined the cost distribution, the board then has to make, or the authority that Shane chairs has to then make a decision about where we price. And we convert the costing model by removing all of the out-of-scope costs and indexing costs to reflect the NEP year. So the cost data collection is 3 years behind the NEP. It's not 3 years old, it's 3 years behind the NEP. So we set the NEP for 14-15 using 11-12 cost data, which means the authority has to adjust historical costs for future prices, and we use an indexation factor, which is a very important calculation, again transparently designed, discussed in our policy framework so people are clear where we draw that indexation factor from. We draw it from a rolling 5-year average of increase in the costs that we see in the NHCDC. So we use a historical rolling 5-year average to correct historical costs to future prices. And that indexation factor is a very important factor because it highly influences the NEP. And it's been declining over the last 3 years. It's declined from 5.2 to 4.7 to 3.9% in the last 3 years. So you heard Shane mention that the health system cost profile changed markedly from pre-GFC to post-GFC, and that's now beginning to be reflected in our numbers. So the cost base that you all work with is tightening, and as a result, the numbers that feed into our NEP are tightening. So the board defines its pricing point, or I shouldn't say the board, it's a colloquial term. The pricing authority, as it's formally known in our legislation, defines the pricing point. It also defines all the price weights, which we've calculated from the cost data, which allows us to publish a price weight list of over 1,000 price weights. And then it applies its own adjustments. Our adjustment regime, which you'll hear about later in the conference, is empirically derived. So when we apply a loading or an adjustment to a special patient circumstance, like Indigenous patients or remote residents across Australia, we apply a loading that is empirically derived, not politically or arbitrarily determined. So all of our adjustment regimes are derived by comparing the National Hospital Cost Data collection for all patients versus the National Hospital Cost Data collection for the special group. And so we've been very insistent, rightly so, that all of our adjustment regime is empirically determined, not subject to lobbying or advocacy. Doesn't mean to say you can't raise an issue. If you feel that there are patient groups that are not adequately recognised in our costing regime and our pricing regime, then you should raise that. The classic one that's still unresolved at the moment, we have no evidence at the moment that culturally and linguistically diverse patients cost more than non-called patients, which for a number of advocacy groups is intuitively incorrect in their view. We've tested the data at a macro level twice now and found no evidence of a basis for an adjustment. But we've had our stakeholders come back to us and say, well, that might be true at the macro level, but what about for the elderly? What about the mental health services, where clearly a called background is far more demanding of services than a non-called background in their view? And thirdly, are we actually using the right data? We're using data that's probably not the most reliable. We're comparing at the moment to establish a called loading. We're comparing patients who are born in non-English speaking countries versus patients born in English speaking countries, and everyone in this room knows that's probably not a reliable test. So what we're doing this year, following feedback from those stakeholders, is first of all testing issues in the elderly, testing issues in mental health, called versus non-called mental health costs, and thirdly, getting better data, particularly, thankfully, there are New South Wales people in the room. New South Wales collects a rich collection of data on language spoken at home. So we'll be using language spoken at home rather than country of birth as a test point. So this debate shows you that there are still some issues unresolved in our pricing regime. Some we think we're pretty settled on, but we'll test them every year. Others are still open for discussion. So again, the pricing framework submissions that some of you might be working on are extremely important and highly persuasive. So once we've established the adjustment regime and weighted all the various information, the pricing authority then sets a price point. And for the last 3 years, it's priced at national average cost. Every now and again, I get to go to conferences with economists, and they're shocked that I'm not an economist. I tell them I did 3 in economics at the HSC, and they laugh at me. And I tell them I did a couple of economic subjects in my MBA, and they're still not convinced. They always say to me, in the Judith Sloans and the Henry Erguses, when I go to conferences, they say to me, you clowns, IHPA, you price at average cost. Everybody knows that's not efficient. And my response has been that our authority has thought this through very carefully. Firstly, the introduction of a national ABF system is a new system for 60% of the country, and a convulsive introduction of ABF would have been very disruptive, particularly in Queensland, WA, NT, ACT. Would have been a very disruptive process. So if we had priced at the 25th centile point, which is what economists often say we should do, and which is where the Kennett government started, I understand, in the mid-90s when ABF was introduced into Victoria, there would have been a convulsive effect in the high-cost jurisdictions. Also, the other important point to understand about pricing at the average is that the average cost itself, as we've already discussed, is growing much more slowly than it has in the past. And so pricing at the average cost in itself delivers a tightening in the system. Now, it's too early to tell whether average cost pricing is delivering real efficiencies in the Australian public hospital system. Anecdotally, we understand the significant improvements, and in reading state and territory budget papers, it's apparent that costs are tightening across the country and that arguably efficiencies are being delivered. But we have just commenced our own evaluation process, which will be a multi-year evaluation. The new commission will need to decide whether it continues the process, but we have commenced an evaluation process to help us answer that question. We won't be able to answer it this year, next year, or probably even the year after. But in about 3 years' time, we should have data that shows whether or not average cost pricing has delivered productivity improvements in the system. But what we do know now from state and territory budgets, particularly in the higher cost jurisdictions, is that it seems to be delivering efficiencies. So that pricing point is something that many jurisdictions and other stakeholders will need to argue with us every year. It's a considered decision. The board, or the authority, I should say, makes a considered decision about where it prices. And despite the offence created to economists, we think we're making a substantial difference at the moment. So once we set the NEP, it's pretty easy to use. You just multiply the NEP times the weight of your service if you're running a clinical unit, either as a medical nursing or allied health director, and you're caring for a group of patients. You can simply multiply for your DRG the price weight that we publish in our list of 1,000 price weights, multiplied by the NEP, and that gives you the total contribution. And for funding purposes, Bob Sent will walk you through later on in the morning how he then converts those price lists and NEP into cash, but I'll oversimplify it and he'll correct me. Effectively, what happens at the end of the day is the multiplication of the NEP times the price weight times the Commonwealth share, plus some ins and outs for other programs. So eventually, the Commonwealth contribution to your service is easily discernible using our price weight and NEP. I spoke perhaps overly lyrically about the NHCDC. It does require improvement. We conducted an NHCDC strategic review, helped by PwC earlier. In fact, it was last year. So out of that review, we've improved the governance of the NHCDC. For a couple of years there, we were quietly running the NHCDC without a lot of supervision from other jurisdictions and other stakeholders. So we now govern the NHCDC through its own advisory committee, which is chaired by IHPA, but involves jurisdictions, private hospitals and private insurers, and private hospitals, not private insurers, and a public hospital coalface, if you like, cost managers who advise us on the corrections or the improvements in methodology that might be useful at the coalface. So we've started this group, and it's starting to deliver its the improvements in the NHCDC that we're looking for. Shane mentioned in his presentation that I was going to foreshadow some major developments in the ABF system in Australia. There are a whole range of policy issues, but here are some of the major technical issues that we'll be working on over the next 12, 24, and hopefully the new commission will keep working on over the subsequent years beyond our work program. Firstly, the movement from version 7 of ARDRGs to version 8. This has been a process that's already commenced. There are hundreds of clinicians already involved. Occasionally, clinicians will approach me and ask that their own clinical issues be considered. It's not too late. If you have a clinical issue that you think is not well dealt with in the classification system, in DRGs or any of the other classifications that I discuss in a minute, then please let us know, because there's a mechanism for us to feed that into the classification design, and we can deal with your issues. We don't necessarily always agree, but there's always a mechanism to discuss your issues. Some of the more recent examples are people are coming to us with rare disorders that they don't think are well treated in the DRG system or well classified. My caution back to them is that we're not going to create micro-populated DRGs because they're impossible to cost and price. So in return, what they've done, a good example is the head of the craniofacial unit at Royal Adelaide and Women's and Children's in Adelaide came to see me recently to say he doesn't think craniofacial units are well treated in the DRGs. So he's gone away to have a look at the DRG structure within the DRGs his patient's currently classified in to see if there are improvements within the DRG that we can generate. And that is now fed into the AR-DRG version, or soon will be fed into the AR-DRG version 8 process once he's completed his submission. AR-DRG version 8 will also, we hope, greatly improve paediatric classification and also some other key issues around the treatment of comorbid conditions and complications. We're also designing, probably our most difficult piece of work is designing the Australian mental health care classification. Mental health costs are not well predicted by diagnosis, as many of you in the room know. So DRGs alone, or diagnosis alone, is not a good basis in which to classify mental health care. So we're designing a new Australian mental health care classification, which will take into account other factors apart from diagnosis. Diagnosis will perhaps still play a role, but other factors will be taken into account. We're about a third of the way through a multi-year journey to build the Australian mental health care classification. We've completed cost driver studies, and we're about to get into the field in probably our most complicated exercise in conducting a mental health costing study across 19 participating hospitals and community mental health services. And those of you there might be some people in the room who, when they get back home later in the week, will be working on this costing study in their hospital or community mental health service or even as part of their jurisdiction. Can I thank you all in anticipation for what will be a major undertaking. But the way it's shaping up and the leadership provided by the IHPA team under James and Health Consult under Joe Scuteri and the various jurisdictions, it's been really heartening to see people take on what is a very challenging task. And I think we're very confident that we'll get some very good information, probably the best mental health cost information. I wouldn't be surprised if it's one of the best data sets around the world, but certainly in Australia. And this is a major project. Those of you participating in it, can I thank you in advance and encourage your further participation. So we'll have a new mental health care classification in 2 years' time. Whether it's us or the new commission, it doesn't really matter. Australia will have a new mental health care classification in 2 years' time. We're also working on ANSNAP. We've partnered with the University of Wollongong, and you'll hear later in the conference about how that work's going. Again, a particular clinical feedback has been, again, we need to improve ANSNAP in paediatrics. Not easy to do because patient numbers are low. And also improve ANSNAP's treatment of geriatric evaluation and management patients, particularly in those with comorbid cognitive impairment. And so we've been testing the ANSNAP work and costing against some new data that we've got on cognitive impairment. So these are the sorts of processes we're working on. We're also planning to review emergency care and the outpatient classifications. This will be a slightly longer time frame. Hopefully with emergency care we can deal with it in the coming financial year. Tier 2 outpatient classification is a big job to improve, but it will take some years. We're also working on improving, or in fact designing, a classification system for teaching and training. I've deliberately left research off that phrase. Teaching and training looks highly feasible. The data seems to be there. We think we can design a classification system. Version 1 won't be as good as version 8 in a decade's time, but we think we can design a good, useful, accurate teaching and training classification system, which I think will be very useful for hospital managers. When I used to run hospitals, I think Shane might agree, I would have loved to have known how to classify my teaching and training costs. Research is a bit more complicated. Research in this country is largely competitively funded through NHMRC and other grant sources, some of which are philanthropic. So our focus has been on the infrastructural costs of research, the base costs of research, to use a poor term, which are state costs. It looks problematic. We're not quite sure if there's enough materiality in state research costs, nor are we quite sure whether we can usefully classify it and productively price it as yet. But we're still talking to stakeholders about that. The research community is very keen for us to do the work and define a research classification system. At this stage, I think the jury's out. So take-home message, we're more and more confident about teaching and training, perhaps less confident about research at the moment. I mentioned the evaluation. Shane mentioned our future at this stage is that we will be amalgamated with 6 other agencies. What I can assure this conference is that the Pricing Authority and myself and my team are positively working on this amalgamation. We will advocate very strongly for the continuation of a national expertise in activity-based funding. Whether there's a role for national pricing is an open question for governments to discuss amongst themselves, but our advice will be there's a very important role for national classification, costing, and probably modelling as well. We'll have to wait and see how the consultation process unfolds and the functions of the new commission are defined, but we think it's a good opportunity to continue national activity-based funding processes, albeit on a voluntary basis in implementation after 1 July 17 in most jurisdictions, but we still think there's a very important role for ABF for the foreseeable future. So all the work that you do is still very important, every one of you in this room.